early detection of developmental dysplasia of the hip by ultrasound. My name is Manish Kumar. I am a pediatrics intern. Okay, so let's start with the authors. So these are the authors, and Dr. Zita Gyurkovits is the corresponding author, and these four authors are from Obstetrics and Gynecology Department from University of Szeged, Hungary. And there are two more authors. They are from Department of Orthopedics from the same university. So I found a little bit about the corresponding author. She has 17 publications and 79 citations. Most of her articles focus on perinatal and neonatal topics, and they claim no financial support in publishing this article. The journal's name is HIP International, and this article was published in 2019 in Italy. On looking at the impact factor of the journal, it is not that high, it's 1.2. So why was this study done? There have been some reports that show early detection and management of developmental dysplasia of hip can potentially provide rapid improvement with relatively non-invasive treatments. So it can avoid the operative management of DDH. However, there is no general agreement on the type of screening, whether it should be only clinical or it can be combination of clinical and ultrasound, and also how to do it and when to do it. There is no general agreement about that. And in one of the older articles, actually this is from a textbook, they have found that morphological abnormalities do not correlate with Barlow and Ortolani signs. So the clinical assessment may not be correlating with the actual anatomical problem. And it can be either false positive or false negative. Both are possible. The study was done in University of Szeged, Hungary, and it was a single institution study. The study population included the term newborns, and they defined as gestational age of 37 weeks or more, and the newborns who were admitted to neonatology ward, that is nursery. The study had excluded certain infants, including low birth weight, congenital malformations, intrauterine infections, or transfer to NICU. Now, whether this study can be generalized to our population. So our nursery population is not different from the study population. So it can be applicable, the study findings may be applicable to our patient population as well. The study was done between January and December of 2012, although the paper was published in 2019. So it's fairly recent enough to be relevant. The study was prospective, but it was not a controlled study, and also it was not randomized. A total of 1636 term newborns were enrolled. That means 3,272 hips, and 65% of all the term newborns were included. So rest of them were excluded, that is 35%, because of one of the exclusion criteria, including low birth weight or malformation or intrauterine infection or transfer to NICU. All the infants who were the participants of the study underwent physical examination, and graph method for ultrasound was performed on the third day. The range of performing the ultrasound was day 1 to day 3, and it was done for all participants. I'll come to the graph method in a minute, but it is basically one of the two major types of ultrasound methods, which is static. So there are two major types of ultrasound evaluation for DDH. One is static method, in which we see the anatomical structure, and that's called graph method. And there is another one which studies the dynamic hip mobility for evaluation of the DDH, and that's called HARC method. So they employed graph method. And if the ultrasound was positive for DDH, then physiotherapy and broad diapering to spread the hips out was performed. And ultrasound was considered positive if the alpha angle was less than 50 degree and beta angle was more than 55 degree. I will come to these angles in a minute. There are several types of hip types based on the ultrasound findings, and among them only QC, D, 3, and 4 were included. I will discuss about the classification in a minute as well. And repeat ultrasound was performed in all the ultrasound positive infants at week 3 and week 6. If at the second examination, that is at 3 weeks, the ultrasound remained positive, then Pavlik harness or fixed abduction brace was applied. And follow-up was continued for 1 year at specific intervals. So just to recap, all the term newborns underwent physical examination and ultrasound evaluation. And if the initial ultrasound was positive, they underwent physiotherapy and broad diapering, and they were followed up with subsequent ultrasound. And if the ultrasound remained positive after 3 weeks, then Pavlik harness or fixed abduction brace was applied, and they will continue to follow it up for 1 year. So now coming to the alpha and beta angles, what they are. So this is the static ultrasound image of the hip joint. This is the normal anatomy, and this, if you can imagine, this is the femur, and this is the neck of the femur. It's the junction between bony and cartilaginous part of the neck of the femur. This is the femoral head, which is cartilaginous. This is the greater trochanter, and this one is the ilium bone, and this is bony part of the acetabulum and cartilaginous part of the acetabulum. So this is the acetabular fossa, and this one is labrum, and this one is synovial fluid. So based on this view, alpha and beta angles were derived. Like the one angle, the one line is drawn at the level of the ilium bone, and the second one is drawn at the bony part of the acetabulum, and third one at through the cartilaginous part. So the alpha angle is between line 1 and line 2, and beta angle is between line 1 and line 3. So normally alpha angle is more and beta angle is less. In case of unstable hip or the hips which are already subluxated or dislocated, the alpha angle becomes smaller because the hip moves in this direction, and beta angle becomes larger. So this is one abnormal hip with developmental dysplasia of hip. So here the alpha angle is 46. Normally it should be above 50 degree. and beta angle is more than 54, 54, and it should be less than 50 degree. So that demonstrates that it is possible DDH. Now, graph method classifies hips into these categories um, based on the alpha and beta angles. The abnormal categories are taken only if the alpha angle is below 50, that means 3C, and beta angle is less than 50 or 60. So 3C onwards will be considered as abnormal or dysplastic hip. So in this study, those patients or those newborns who had 2C, 2D, 3, or 4 were uh, uh, intervened with the initial broadening of the hips, like broad diapers, and physiotherapy was started. Statistical analysis that was used was chi-square test, and p-value of less than 0.05 was considered significant. Sensitivity and specificity of clinical examination were calculated. So what did they find? The results included, based on the physical examination, out of the examined hips, number of hips that is 3272, only 67 were found to be positive, and rest 3205 were did not have any physical abnormality. So ultrasound showed that there were a total of 70 hips that were found to be abnormal, and if we see the positive physical finding hips, out of them only 14 were found to be positive, and the ones which had physical examination negative, ultrasound was found to be positive in 56 of them. Whereas out of the positive physical examination hips, 53 were found to be negative, and like rest of the negative hips other than the ultrasound positive were negative. So 3149. So based on these data, we can calculate the sensitivity of the physical examination. So sensitivity would be true positive divided by true positive plus false negative, and that will give 20% as the sensitivity, and 95% confidence interval was this, which is quite broad. Whereas specificity was can be calculated based on true negative divided by true negative plus false positive, that's 53, and that comes to 98.3%, which is pretty good specificity, and the confidence interval is also narrow. Positive predictive value, which is the true positive divided by true positive plus false positive, is only 20.9%, whereas negative predictive value, which is true negative divided by true negative plus false negative, will be 98.2%, which is high. So the specificity and negative predictive value are high, whereas sensitivity and positive predictive value of the physical examination are low. So accuracy, which is the trueness of the test, can be calculated with true positive plus true negative divided by all, and that gave rise to 96.7%, with a narrow confidence interval as well. So based on this, we can see that if the true DDH is present, if we consider the ultrasound as gold standard, then physical examination can miss many of them, like 80% can be missed. So only 20% will be positive. Whereas if there is no DDH, then the physical examination will be negative in most of the cases. Okay. Now, Based on the hip types, they found that the number of abnormal hips were equally distributed among different types, except for type 4. Only one abnormal hip was in this category, whereas all others had about 30%, like 2C, D, and 3. And out of them, the physically negative, uh, like if we see how much of these different types had impact on the physical examination, so it was not much different. So about two-thirds were positive, sorry, two-thirds were missed by the physical examination. And the type 4 was also missed by physical examination. So we cannot assume that if the DDH is severe, physical examination will be positive, and in milder cases, it may be missed. This study did not find that. And as in many other studies, the females predominated the males among all the different types of the hip. Now, they studied the risk factors irrespective of the physical examination findings, and they found that in literature, there are several risk factors documented. Out of that, female gender, macrosomia, breech presentation, and positive family history are included. However, based on the significance values, this study found that the female gender, breech presentation, and positive family history were included, um, were found to be risk factors, but macrosomia was not found as a risk factor for DDH. And a total of 70 hips, but total of 55 newborns were found to be DDH positive. And out of them, 13 had either, that is 23%, about 1/4 had either positive family history or were born in breech presentation. And interestingly, more than 50% of the newborns with DDH, which was found on ultrasound, had neither any positive physical signs nor any risk factors except being female. So other than being female, they did not have any risk factors, and they also did not have any physical examination findings. So they want to emphasize that it can be easily missed by physical examination or risk factors. So on follow-up, the following findings were noted. So on the first examination that was done within 3 days of life, as we have already seen, these many hips were found to be abnormal, and in various categories they were distributed as 1/3, 1/3, and 1/3 approximately, except for the type 4, which had only one hip. Follow-ups were attended by all except 5 patients. So 5 patients were lost, including the one with type 4 hip that was the most severe form. And they have mentioned that the patient had left the country and came back later after a year when operative procedure was done on him. But the other patients followed up except for 4, and they found that at 3 weeks, when they did their first ultrasounds, they found that about 90% of these patients had turned already negative based on the ultrasound. So if you remember, all these infants who were found to be positive were instructed to go for physiotherapy, as well as hip separation techniques like broad diapering was performed. And after 3 weeks, 90% became negative. And at 6 weeks, that's the second follow-up visit, at that time, all the patients who followed up had normal hips at this time. And they also informed that on subsequent follow-up for 1 year, no cases of late diagnosis was noted. So they did not find that findings changed on subsequent follow-up until 1 year. So their conclusions were like the physical examination has a poor sensitivity, 20%, compared to the graph ultrasound method. And physiotherapy and broad diapering soon after diagnosis avoids the need for surgical intervention, as they have shown that almost 100% of the patients improved with these maneuvers and did not require any surgical intervention. The one patient who had lost to follow-up was assumed not to follow the instructed advice, and he ended up in surgical intervention. The universal screening model with graph ultrasound technique is a valuable tool for identifying infants with DDH. That was their main conclusion. And in fact, in many of the European countries, they follow universal screening method. So what is the implication of these findings to us? So these results are promising and may be applicable to our patients, but this study was not a randomized controlled trial. So external validity of the study, that is applicability to our population, may not be very accurate. So we need more randomized controlled trials. Unfortunately, there has been no randomized controlled trial done so far on this topic. Also, longer follow-up may provide more information, although they followed up the patients for 1 year, possibly. If they are able to follow up for longer, they may get a little more information different from what they found, because developmental dysplasia of hip can also develop later in life. And also the sample size as such for this condition was not great. So, and the study can be done in a larger population with randomized control trials. So their finding was that ultrasound became normal by 3 weeks in majority and by 6 weeks in almost all the patients. So this can be considered in a different ways. Like we know that there are some inter-observer variation among the radiographers. So whether that has caused this finding to be positive, like whether the initial positive hip was false positive. Other possibility is that whether the self-improvement would have happened without intervention. We cannot tell that the intervention has caused the improvement for sure, because the study was not randomized. Or it may be true improvement with intervention, but it's difficult to say at this point. So now coming to what our AAP, American Academy of Pediatrics, recommend. So they do not recommend, or they recommend against universal screening of all the newborns with ultrasound. The reasons behind this guideline is that the ultrasound is operator dependent, the availability is questionable, and it may increase the rate of overtreatment because of false positive results, possibly. Inter-observer variability is high, and probably there are some increased costs associated with universal screening compared to just physical examination. So American Academy of Pediatrics has provided the flowchart for the screening guidelines for these patients or these newborns suspected to have DDH. So first, the physical examination is performed. If the physical examination is positive, the patient is referred to orthopedist. If the physical examination is inconclusive, then the follow-up examination is performed after 2 weeks, and if the examination is positive, then orthopedics referral is made. If the examination is definitely negative, then we'll see that in the next slide. On repeat examination, if the physical examination is negative, then again, whether it's inconclusive, and if it is definitely negative, then we can go to next slide. And if it is positive, if it is inconclusive, then orthopedics referral is made, and ultrasound at 3 to 4 weeks is performed, and risk factors are determined. So, as we saw, if the initial physical examination is negative or initially inconclusive but later found to be negative on follow-up, then we need to identify the risk factors. If there are no risk factors, then periodic follow-up can be done. And at any point of time, if the examination finds positive findings, then orthopedics referral is made and ultrasound should be performed. So ultrasound is usually done when the infant is less than 5 months, and X-ray is only done only after 4 months, because before that it may not show any finding. And if the risk factors are present, then we have to decide what risk factors are present. Like if the patient is girl, then periodic follow-up is needed. If the patient is a boy and there is a family history, then periodic follow-up to box 17 is needed. If the patient is a girl and family history, these are the two positive risk factors. So future imaging can be done, but that is optional. If breech is present, breech presentation is found to be the strongest risk factor associated with DDH. So even in boys who are at low risk, if they are born with breech presentation, future imaging is recommended, but that is optional. And if two strong risk factors like breech and GERD are present, then future imaging is recommended. So I'll stop here, and I'm open for the questions and discussions.
It's Dr. Zielinski. Can you hear me?
Yes, Dr. Zielinski.
Okay. The thing that I would add, this is a shorter study with only being a year. I absolutely have seen hip dysplasia continue on past a year. Basically, as the femoral head grows, the acetabulum does not grow over the top with it, and so you get under coverage. It is definitely seen that a lot of babies do improve on their own. So automatic ultrasounds for risk factors at 2 and 3 weeks, we are getting away from that and waiting until the 6th week, as you presented, since so many kids do get better on their own. exam and history really is a big portion of it, especially that breech. Breech is the highest one I've seen, and in the things that you presented, 10% of all breech babies were positive and 12% with a family history. So that's one to consider getting an ultrasound or an x-ray at about 8 months just to make sure everything is going okay. And the exam often doesn't really show a whole lot, so that's absolutely correct that the exam can be negative. That's why you look at other things. Is there a hip click? Hip clicks are common. I've had one my entire life. My hips are fine, but every now and then they are associated with dysplasia of the head. Same with asymmetric thigh folds. So if those are a little bit uneven, can it be normal? Absolutely. But if you have asymmetric thigh folds and a couple of risk factors, follow up on it. But overall, good presentation. Oh, one other thing. We don't generally do a lot of double and triple diapering here just because so many people have disposable diapers and those kind of crush in between the legs and don't do the same good as the cloth diapers do, which is what historically triple diapers were. There is another device out called the Halo Healthy Hip Diaper Cover, which is a firm padding that goes in a diaper cover between the legs. I'd encourage you to look that up. We use that for some at-risk kids. And we definitely do not do any type of physiotherapy here. Don't think it necessarily helps, but we do recommend carrying the child with the legs spread apart as they would do commonly in countries that carry the children on their backs.
Great. Thank you, Dr. Zielinski. That was very helpful. All right. If there are no more...
Oh, I have a question.
Sorry.
Hey, can you hear me? Sorry about that. I had some audio. Is Dr.
Oh,
Ward.
okay. Yes,
Yeah,
Dr. Ward.
I missed some of your presentation. I apologize. I had some connection issue in joining in. I wanted to ask you, kind of with the limitations of this study, it was certainly, this is more of a diagnostic focused study. I had trouble understanding the chart. It was, I believe it was table 2. I don't know if you have that there. No, not that one.
Let me, I think. This
It was
one?
the one where they looked at the, these male to female ratios. It didn't look like when they ran the statistics on it, it was just confusing because they would have a low number of those who actually had the dysplasia in the female risk factor as compared to those who did not. And there was a lot more. And it just was a very confusing chart. And I didn't understand it. And I think they did kind of chi-square with it.
Yes.
Yeah. So, yeah, right here. This is it.
Okay.
Like, how? Like, can you explain that to me a little better? Maybe I'm just looking at it wrong. I am a little sleep deprived.
I understand. So I didn't go into details of chi-square, but the DDH positive was 45 compared to 775 negative. Yeah, actually, I'm not sure how they arrived at the p-value of.
It's a little funny there because it looks like you have actually more who are negative that are female.
Yeah.
And when I looked at that, I was like, well, your female was actually a risk factor for not having it based on how they presented that chart. But it goes different of what they were saying. And I'm not sure if this was written in a different language to start with. And because there were some grammatical errors in there. I don't know if you noticed that.
There were many spelling and grammatical errors as well.
And then what I would have you do, so this is the journal that this was published. This is an interesting thing. Was Sage, I believe. Is that correct? Was the
that's Sage.
Yeah. So if you Google, so what's this thing called? Who's afraid of peer review?
Okay.
So if you Google who's afraid of peer review, it touches on a actual study that was done for open access journals. It was published in Science, I believe. And what happened is a guy submitted to Sage and about 80 other journals kind of false. He made up a study and he would see if it would get published. And Sage was one of those that actually published the article and accepted it. And he later went back. It was kind of an investigative journalist type of thing.
That's
And it
interesting.
really, and this was around the time this data was collected, but it was kind of 2013, 2012.
Yeah,
They
this that yeah.
they have since kind of tried to make their appraisal of literature, their review process a little bit more robust. Because I think this was published in 2019, but it was definitely interesting knowing that SAGE was one of those journals that
Mm-hmm.
had kind of a lower standard, which
Okay.
kind of, sometimes a journal is important when you're appraising some of your literature and the history of
Mm-hmm.
issues
Yeah,
they've had in the past. And I thought
that's
I'd
right.
share that.
Yeah.
Hey, it's
Thank
Dr.
you.
Zielinski again. Can I also comment on the same slide that's up? I might be able to answer part of your question. I still think, yeah, the values may have been off in the chi-squared, but I think in the female, the p-value, looking at those numbers, you're like, how does that get a p-value of that versus the family history, which is same and clearly different numbers? I think it has to do with the number of females positive overall versus male positive overall. And that's going to be a significantly different number, and that's where the p-value becomes so high. And also, I did want to add, while this is up, why is macrosomia not statistically significant, even though you look at the numbers and it might seem like it is? The reason for that is, as long as there is enough amniotic fluid for the child to move around, it doesn't so much matter if the baby itself is large. It's as long as there's fluid for it to move. That's also why twin birth is actually not a risk factor, as long as there is enough fluid to move around. Now, if it's a twin that one of them is breech, well, yes. But twin birth alone actually is not, it's a trending toward, but not a true risk factor.
Okay. Thank you.
And then the other thing I was going to ask you about for diagnostic testing, this is purely kind of EVM stuff.
Okay.
When you had mentioned that the positive, if you're using your physical exam, it's very low sensitivity, but the specificity was, I believe it was around 90.
Yes, that's right. Mm-hmm.
So how do you feel about physical exam with that data, with your sensitivity and your specificity? How do you look at that?
So I would look at it like if there is a true like DDH, the physical examination can miss in 80% of cases. It will be positive only in 20%. Whereas if there is no DDH, the physical examination will be negative in most of the cases, like 98.3. So it's good for ruling in, but not for ruling out the diagnosis. I don't know whether I'm
So
right.
yeah, if it's positive, it's helpful. And if you're just purely looking at, like, is my diagnostic test decent, really good, or really bad, there's what's called a Yodan Index, and that's where you take your sensitivity and your specificity.
Okay.
So you take essentially 98 plus 20, and then because you're around 110, 120 or so with that, and then you subtract it from, I think it's 100 or so. And if you're below 50, that's not a very good test. If you're above 50, that's a pretty decent. And then above 100, like, you've got a gold standard test there.
Okay.
And whereas this case, you have such a low sensitivity that it's not a great test, a great diagnostic test.
Mm-hmm. All right. Thank you so much. Mm-hmm. And did you say Yodan Index?
Yodan, like
Yodan.
Youden.
Okay.
Yodan.
Good to know. Sure, I will look at it.